Moving on to our next session, which is sponsored by Bharat Biotech. Enteric fever remains a significant public health concern and continues to burden developing nations like ours. Despite advances in medicine, its persistence underscores global disparities in hygiene, vaccination, and antibiotic stewardship. I would like to now invite our chairpersons for the talk, Dr. Surbhi Rathi and Dr. Nikita Shah on the dais, please. Dr. Surbhi Rathi is the Professor and Head, Department of Pediatrics at TNMC and BYL Nair Hospital, Mumbai. She has a keen interest in early intervention care and is in charge of the Early Intervention and Rehabilitation Center for Children at Nair Hospital. She is truly an administrator par excellence. Dr. Nikita Shah is a Senior Assistant Professor, Department of Pediatrics, LTMMC, and the Organizing Secretary of DAFPAL CME 2025. She has previously served as an Assistant Professor in the Department of Pediatric Oncology, Tata Memorial Hospital, and is also a key member of the Pediatric Palliative Care Team at LTMGH. I request our chairpersons to please introduce our speaker for this session, Dr. Upendra Kinjawadekar. Thank you.
Very good morning to all. Before I start, I would love to tell Dr. Radha that lecture was par excellent. So may we have Dr. Upendra Kinjawadekar. He is a consultant pediatrician at the Kamlesh Mother and Child Hospital and Apollo Hospitals, Navi Mumbai. He has been a member of the International Pediatric Association's Committee on Non-Communicable Diseases and Mental Health for a very long period, and of course, the National President of Indian Academy of Pediatrics. Very well known for his infectious diseases. I hand over the lecture to be delivered to you, sir.
Thank you so much, respected chairpersons, for the kind introduction, and of course, always a pleasure to be back in with the DAFPAL family. And I can see many of the Nairites joining in. So may I suggest we can have, so many of them. And of course, Dr. Poddar sir, one of the senior most pediatricians of the city, sitting over here, again a Nairite. May we have DAFPAL family expanding its horizon and taking Nair with us for the future conferences. I think that would be a good thing, looking at the presence. Look at that, madam is also here. So it's all in all, don't show all your loyalties.
Yes, she's an original Nair, born and brought up child of Nair.
Let's not get into that. Of course, this is though the sponsored session, but let me say that I have no conflict of interest to declare, though being on the advisory board of many of the vaccine producing companies. But I would like to put my sincere thanks to my dear friend, Dr. Vijay Evle, for sharing so much of scientific data while preparing this talk. And of course, we are missing him because he is in Australia with his family there. So here we are talking about typhoid, and all of us know, very important to understand the disease burden. Is there any need to talk about it? Everybody knows about it. Antimicrobial resistance, all of us know. In fact, I remember when Dr. Manglani joined Sion Hospital, that was the time that around, I remember my residency began in '87, that we had the first time something called as Dombivli fever, if those of you who were practicing that time would remember. And first time everybody, chloramphenicol resistance, what is happening? And suddenly ciprofloxacin from 89, 90, 91, we are all talking about. And madam proposed that why can't we start, ampicillin was her favorite before that. And every child was responding to ampicillin. And suddenly the chloramphenicol, of course, because of the bone marrow toxicity we were scared of. And then came the ceftriaxone, of course. So that time madam's preferred drug, madam, if you remember, was amoxicillin, and that also used to work. So that was a different era, 87, 88, 89. But now we have moved far away from that and ahead of that. Look at the prevalence global, all of us know it's a huge, almost 12 million, that's a huge burden, and we are contributing to almost 50% of it. That's again enormous. So India's enteric fever burden, along with our neighboring countries, maybe Nepal, Bangladesh, Pakistan, you name it, and we are all having together the endemic burden we are contributing is enormous. So India remains central to the global strategy to control typhoid with robust surveillance, vaccine introduction, and improvement in WASH, which is critical. The water, sanitation and hygiene, all of us know that everybody has to work on that. But of course, when we have a beautiful vaccine, wonderful vaccine, time-tested vaccine, why not use it? And this is typhoid fever use and misuse of antibiotics. You can see that culture facilities are not employed. You would be not shocked maybe to understand that less than 3% of individuals are diagnosed by blood culture. I understand the sensitivity is limited up to 60%, but still we are using only 3% of us. Rest of us are all considering there is something called as empirical treatment, but we have empirical diagnosis of typhoid fever, and the child, the moment the fever crosses third day, either is on cefixime or is on cefixime plus azithromycin, or you name it, any combination, and then nobody knows that what was ultimately the child was suffering from. So every fever of typhoid, every 3 patients, 25 are undiagnosed. So that is a huge thing, that we are misusing our antibiotics. And of course, this is what happened. We know over the years before 48, the mortality was to the tune of 25%. Fortunately, it has come down tremendously. And then unfortunately, the 80s, I talked about the MDR strains, the large fluoroquinolone resistance, 90% of South Asian strains becoming resistant, and then ceftriaxone. And now, scary part is all of us are reading sporadic reports of ceftriaxone resistant enteric fever. I'm scared to see that my practice, if I have to suspect each and every alternate patient, could this be a ceftriaxone resistant enteric fever? Oh my God, I don't want to face that day, and let's be very judicious as far as our antibiotic use, and only after establishing a proper diagnosis. And this is what happened. And this is both ways, the plasmid as well as chromosomal. The plasmid has a beauty that it shakes hands with everybody. It has no enemies. So it takes resistance from E. coli and gives it to Salmonella. Salmonella gives it to somebody else. So it is shaking hands with gram positive, gram negative, no barriers. We may have barriers while speaking, but then they do not have any barriers. So they spread the resistance like anything. So that is what is plasmid. So this is what happened in the fluoroquinolone resistance was considered. Mostly it was happening, and then beta-lactamase resistance also. As far as chromosomal resistance, chloramphenicol was the first one. And of course, there is a quinolone resistant determining region QRDI on chromosomes, which also contributed. Plus there were some efflux mechanisms, even azithromycin had some mechanism. So all in all, the antibiotics exposure itself causes the adaptation, survival of the fittest. Salmonella typhi have to survive, and then they try to evade the mechanism, different mechanisms. So we have to have improved diagnostic, surveillance, and vaccine implementation. All in all, this is what is important. So wash, but plus let's wait at that point of time. Good diagnosis, proper antibiotics, wash important. But why not use a vaccine which it is proven to be useful? Why not use it? So how has been the journey? Those again belonging to my era, remember in school days, we were all given this TAB vaccine. The heat inactivated phenol preserved efficacy was up to the tune of 51 to 80%, but 30% of had reactogenicity. I remember when our class, this vaccine was given, next day almost entire class disappeared. We could not go to school because extremely painful. Though effective, it can still be procured and can be put in use, but nobody is using it just because of the huge reactogenicity up to 30%. Then of course came the oral one, that Ty21A, the gal mutant, cannot synthesize VI. That was very important, which is giving the virulence to this Salmonella typhi. And if it is not being affected, then why to use it? So liquid and capsule form, you remember the capsule size was also very large, alternate day for 3 days. And then of course it is not available, not used. Of course some of the countries, and it can be restarted, but nobody is there to take interest. Only in Chile there was a good trial. Then came the conjugate vaccine, polysaccharide vaccine, first the polysaccharide vaccine, subunit vaccine developed from wild Salmonella typhi. 25 microgram was taken into consideration, but all of us know the polysaccharide themselves have inherent limitation. They cannot be used in less than 2 years. There is no memory, so why to use it? So, and if I quote you a study that there was a 10,000 blood culture sample study done, grown Salmonella typhi, and less than 4 years was 27%. Though all of us know that mostly we say typhoid between 5 to 15 years of age, 27% is a huge number. So we have to ensure the child is protected as early as possible when we can give that vaccine. So that's why this inherent limitation of polysaccharide itself, you have to have something better. And then of course came the conjugate vaccine, which overcame all these challenges, and conjugation with different things, and I'll just go elaborate more on that. So now, right now we are into the era of conjugate vaccine, which has been proven to be of use and definitely there. So it has been conjugated with what? We had the, the exotoxin we had taken from Salmonella typhi fruendis, one which came later on, but the first one was Pseudomonas aeruginosa, and that was a great study. In fact, why this vaccine was not into commercial use, there are many reasons behind it, but it was the first vaccine which gave confidence to others to try something different. And of course, the tetanus toxoid, which is used by many of the companies right now, then CRM will be talking, and of course, diphtheria toxoid is also been used with this. So what are the different manufacturers are using it? The 25 microgram is the one which is used by most of them. The one which we have talked about, the National Institute of Health first gave from Pseudomonas, then tetanus toxoid, then of course CRM 197 and diphtheria toxoid by some of the companies. But most of them 25 microgram. There was a debate whether 5 microgram, 12.5 or 25. What is better? Right now the science says probably 25 microgram has been standardized, can be put in use, but 12.5 future may, if better conjugation methods are available, could be used to create the same kind of immunological response. So here the difference between procuring from Salmonella typhi and Citrobacter fruendi. Remember, Salmonella typhi has a large molecular weight, and that's why filtration and conjugation was a huge challenge, and which was overcome by Citrobacter fruendi. And that's why one of the companies is using this, and then they are already it is available, and it is found to be non-inferior to the one which is already available. So this is because of the low molecular weight, better filtration and conjugation, so it can also be used. So all in all, it all started off with the conjugation done by Bharat Biotech. Tetanus toxoid was the first one, and we can say they have set a benchmark. Large number of field trials, that the phase 1, phase 2, phase 3, large trials. It has been done not only in India, neighboring countries, European countries, and all in all we can say the rest of the vaccines are compared to this vaccine and non-inferiority is decided. If we have a PCV13 comparison, all of us know that Prevnar is the most studied one. Anyone wants to come out with a new 13-valent PCV vaccine has to show non-inferiority to this. And this state has been achieved by Bharat Biotech's typhoid conjugated vaccine. So that's why it is, we can very well consider as most well studied. So this is a phase 3, one of the largest study which was done in almost 981 and 6 months to 45 years. So they had a two cohorts, one was 6 months to 2 years and one was 2 years to 45 years. 6 months to 2 years there was no parallel arm. So that was an open label study, only typhoid conjugate vaccine was given. But whereas 2 to 45 year old, again they were divided into 300 each. One was given only the typhoid conjugate vaccine and other similar vaccine which may not interfere with the immunological response of TCV. And what they found, actually typhoid, all of us know there is no correlate of protection which is known, but anti-VI IgG is considered as a surrogate marker, which we can say that probably if it is up to certain levels, maybe 4.3 microgram or 3.52 ELISA units, you may consider that it is given good kind of protection. After revisiting this recombinant exotoxin of the Pseudomonas aeruginosa, they felt that 2 microgram is also good enough. So having said that, that means probably, as I said, the original strength of Salmonella typhi, which was taken as 25 microgram, why we can say probably a lesser one could also be used. That is what it has come to this level. So this is, the seroconversion rates as well as geometric mean concentration are well above the desired protective level if you use this vaccine. And this was another challenge came with that Pseudomonas aeruginosa. What was the timing that we can give? None of these vaccines, because maternal antibodies are going to interfere with everything. So we are going to start off with 6 months, we want to give protection to this child. 6 to 9 months, 9 months again the measles vaccine come. We want to reduce the number of visits of that child. So will measles vaccine interfere with this result? So there was a great study. So there is no interference. So we can very well at the same sitting or the same visit use measles containing vaccine as well as this typhoid conjugated vaccine to the same child, and it has absolutely no interference as far as immunogenicity is considered. This was a great trial which was done in Oxford, and this was by Dr. Andrew Pollard. And what they did, this is a gutsy trial, 103 volunteers aged 18 to 60 years of them. They were naive, they had not taken vaccine, nor they had any history suggestive of typhoid fever. They were given a vaccine, following which they were given a load of Salmonella typhi ki le lo, Salmonella typhi kha lo aur dikhao ki kya ho jata hai. And look at this, what happened, challenge with Salmonella typhi after 1 month, and they were not only followed for fever about 38 degree, blood cultures were also drawn. And this was followed up, and it showed that 87% efficacy, less severe, even if those who had some disease but they were was less severe. Of course, all of us know Oxford, UK is not an endemic country for typhoid fever, but still this is the only human challenge study which has given confidence that probably after giving single dose of typhoid containing, typhoid conjugate vaccine, probably an immunogenic level which is there, which is good enough to protect that individual. And same thing was, again converted, again same Andrew Pollard also said. So this is just by doing blood culture, but every time should I do a blood culture or follow up that child with fever? No. So there has to be a serologic correlate of protection. Again, anti-VI IgG came to rescue, and it was found that if it is a certain level, probably sero efficacy is 85%, much above what was seen by the polysaccharide vaccine, and still it could protect. So all in all, this gave WHO confidence that probably now is the time that typhoid can be used in endemic countries wherever it is required. So what WHO in 2018 said, a single dose of 0.5 ml of typhoid conjugate vaccine from 6 months in adults up to 45 years. So this is 2018, we have come much ahead of that, and there are a number of newer studies which probably give us confidence that this can be used further ahead from 45 to 65 to even 85 years of age. I will just share the studies with you. So potential need for revaccination was not yet clear, but all of us know that immunological edifices are not very well developed in a young baby. So I want to protect the child from 6 months onward to lifetime. So will that one single dose be enough? That is always a question, and that is the science is, everybody's researchers are trying to find a scientific answer for the same. And let's see what other studies apart from this were done. Of course, in Nepal, Lalitpur trial, a huge trial, 20,000 subjects were given. The MCV is given because it does not interfere with the TCV response. So that is on one arm was given. 1 year efficacy 85%, 2 year follow-up 79%. Malawi study was also, now this again gave confidence that none of the other vaccines interfere with the typhoid vaccine. So you can very well give this. But I want to draw your attention to one important scientific fact. All of us read paper about confidence, 95% confidence interval. Look at this. When Malawi trial, less than 2 years, it is 70.6%, and the lower bound confidence interval is 6.4 to upper bound is 93%. What does that mean? So it means I have 95% confidence that this vaccine will work from 6% to 93%. So if that 6% comes to 0, then the study sample size, this has no meaning. So the limitation of this study was that probably a sample size was less, the population was widely varied, and that's why we said, so anytime you see a paper with a 95% confidence interval, see to it that the lower bound level should also be ideally above 50, and the upper and lower should have a minimum. Look at the other figures. 45 to 93, 66 to 86, 63 to 89, they're fine, acceptable, but anything the lower bound is so less and the variation is so high, always have question about probably. So if a child less than 2 years, if it is given a single dose, probably it may not have long lasting effect. So that is what the scientific study shows. So Bangladesh, another study which showed is a cluster based, in Dhaka it was done, and they showed that there was no herd effect, but as far as the population which was given vaccine, great effect by 2 years also 83%. Pakistan, Prince Ali Khan University, probably Lahore, they did this study, 95%, and we know that the clade H56 which came from Pakistan, we are all worried about the shift triazone resistance which was reported in 2016. Fortunately, it has not grown big out of proportion, but we are worried about that part. So here also, even against XDR, 98%, and Zimbabwe also trial showed the cases dropped from 23% to 0% if there was a mass vaccination program. We tried, Navi Mumbai is the only city in India which has tried a mass vaccination. In fact, the plan was to give more than 200,000. So we could ultimately give only 113,000, because unfortunately the moment the last vaccine was given, same year the COVID started and the entire program was fizzled out. If it was continued, and what has happened, we continued is all those who were vaccinated were followed up. Anytime they had fever, there are 6 centers in Navi Mumbai which report this blood culture positivity if there or not there to those who are vaccinated, and in general the community prevalence. As it has been shown, the vaccine effectiveness is 83.7%. The other confidence, this Navi Mumbai trial of huge trial showed safety. hardly any side effects as far as typhoid vaccine, and all of us have used it for many of years, and then we know the hardly local interactions. There is absolutely no major side effect as after this vaccine was introduced. And Ghana and Democratic Republic of Congo also have certain ongoing studies. So finally, I would like to just say that anything after a vaccine is given, we can see that seroconversion with a single dose and with a booster dose. As you can see, single dose, though it remains high, 60% of the population still has 4 times more seroconversion even at 7 years, even if you have an open label study or a randomized control trial. But if you give the booster dose, it still remains higher. Maybe some clinical or subclinical infections may boost your immunity, but you cannot say that as far as when you give the vaccine to a very young child. For an older child, you may say that, but it cannot happen. You cannot take chances on that. And of course, another thing is the avidity index is so high. What is avidity? We have affinity and avidity. Affinity is attraction between antigen and antibody, and avidity is the strength of the bond between antigen and antibody. The moment you have a high avidity index, that means that antibody has the power to go and attach strongly to that antigen and kill it. So that is what is the beauty of, and if this typhoid conjugate vaccine can give us a high index of more than 60%, why not? Even 7 years studies have proven this. So important virtues, proven safety, proven efficacy, non-interference. But finally, I would just like to say that postulated protective layers are there. Young children have less opportunities to get natural boosting. Avidity is also less in unboosted subjects. Lack of certain immunological edifices, as I said, and it's an inoculum-based disease, all of us know. So even after having a typhoid fever, we always recommend that patient has to take one more vaccine, because we are not sure the kind of protection and the duration of protection with that natural infection can give this child. So for best protection, it is recommended to have 2 years. And these are final couple of slides. To you and I, those who are, a plus in age group, so 65 years you have not had, you have a great study to show that this gives protection even up to 65. And if it was not enough, the 6 months to 85 years, June 25, this is the latest publication which has shown that typhoid vaccine also comparative immune response of type bar TCV, extremes of age, Indian experience, what it has shown that reported to be safe and induce similar antibiotic response even in 65 as well as up to 85 years of age. So all in all, it's a great vaccine. We must use it. Use it single or double dose, but those who are not using, at least start using it. But we must understand the scientific basis behind it and start using it so much. And I think finally we all need to have it in our national immunization program. We have rotavirus, we have also PCV. Why not? All of us know India needs to have, it's an endemic country. If it comes in the national immunization program, all the factors are proving for its use. And I'm sure there is not far that we would be having it in our national immunization program. Thank you so much.
This is one small video about the typhoid awareness.
The bacteria Salmonella typhi can easily spread when people eat or drink contaminated food or water. आप सोचोगे, अरे सिर्फ fever ही तो है, but it can be more than that. If left untreated, it could damage other organs. The good news is, typhoid can be prevented by getting vaccinated. इसलिए ये बहुत जरूरी है that we protect ourselves and our loved ones from the disease. Sanitation protocols maintain करके, unhygienic surfaces छूने के बाद हाथ धोकर और internationally या locally travel करने से पहले टाइफॉइड का वैक्सीनेशन लेकर यू कैन चूज प्रिवेंशन. तो जाइए, कंसल्ट योर डॉक्टर फॉर अर्ली वैक्सीनेशन. और भूलिएगा नहीं, ये कोई छोटी मोटी बीमारी नहीं है. टाइफॉइड नीड्स अटेंशन.
Thank you, Dr. Upendra, with all your facts, figures, tables, trials across the globe, and the deviations. I promise, in fact, everybody promises, I think, we will not deviate and continue our affinity with the TCV vaccine.
Thank you. Yeah, please.
Thank you, sir, for that extremely informative overview of enteric fever. I would request the chairpersons to present our speaker with a token of gratitude. I would now request Dr. Sujata Sharma to present the chairpersons with a token of gratitude.
A very thoughtful gift. It's written plants grow people, people grow plants.
Thank you all.